Hi, my name's Trang Weidemeyer. I'm with the Oregon Cost Growth Target Program. Yes, a reminder, this meeting is being recorded and will be uploaded to the Cost Growth Target Program tag website afterwards. Okay, so let's go through roll. I'm going to do what we've been doing. We've been calling out frequent tag attendees, and if you are a staff member affiliated with that, please announce your presence and I will take you down on my spreadsheet here. All right, do we have folks from Advanced Health? And if you are having audio issues but can still hear me, please also feel free to put something in the chat and I can see it that way too. Any folks from Aetna?
Sorry, I was talking. Did you get the names there?
Oh, Tracy.
Yes, Tracy, Alicia DeHaven, and John Navicka.
Okay, thank you. All right. What about All Care? Any people joining us from All Care today? I know we're still letting in a couple folks. How about Care Oregon? Okay, Cigna.
Good morning, Jason Loftus from Cigna.
Hi, Jason.
And Jean Wertz from Cigna is on.
Hi, Jean. All right, moving on down. Anyone joining from Health Share of Oregon? Okay, Humana. Okay, thanks. I have Humana in the chat. Kaiser.
Oh, yeah, this is Keith Grolan from Kaiser Permanente.
Hi, Keith. Okay, rolling on through. Any folks from MODA? Any people representing Medicaid? Thank you, getting some in the chat. Pacific Source.
Hi, this is Jeanette Sims from Pacific Source, and I have Kyle Harada with me.
All right, hi, Jeanette. And Kyle. How about Providence?
Good morning, this is Drew Tarab.
Kristen Downey and Jackie Fabric from Providence are also on.
Hi, Drew, Kristen, Jackie. All right. How about Regents, Cambia?
Hi, this is Jared Collins from Cambia.
And Vince Porter is on the phone as well.
Hello. Thanks for those of you using the chat for me. Any folks from Samaritan? Okay, how about Trillium / HealthNet / Centene? All right, thank you. Umpqua Health Alliance.
Sue Goldberg.
Hello.
Neil Patel.
Hi, Neil.
Enoch Gray.
Can you say that again? The last person?
Gray.
Greg.
No, Trang, I got it. It's Enoch.
Okay, thanks. Any folks from United?
Hi, good morning. This is Anna Morales with United, and we have our data team on the call as well. Susanna Hugh, Peter Hindle, and Laura McDonough.
Okay, thanks. What about Yamhill CCO?
Good morning. You got Larry Soderberg and Amanda Champagne from YCCO.
Okay. Thank you. Let me see. List order kind of got a little mixed up. Okay. Are there any other cost growth target data submitters, any data reporters, organizations I did not call out? Okay. Moving down the list, any folks that are not from OHA, but are also on the call. So these are other Oregon State Department staff, people from other state agencies. Megan, I have you. Megan Burns, I have you.
Thanks.
Gail Woods is here from DCBS.
Hi, Gail.
Chris Kuhn from Health Authority.
Hi, Chris.
Adrian Zachary Goldman here.
Hi, Zachary. Well, let's just open this up to other folks. So these are other participants or other OHA people.
Richard Gibson from Comagine Health.
Hi, Richard.
Liz McCarthy from OHA.
Ishan Song from OHA.
All right, and thanks for those of you that are using the chat with me too. Let's round it out. Are there any public attendees? Any members of the public? All right, I think we have them all. Yes. Okay, so let's get started. Sarah?
All right, thanks, Trang. Hi, everyone. Welcome to our second June TAG meeting. Thanks all for joining. This is our last TAG meeting before we finalize the data submission template and specifications for this initial data submission. So I'm going to briefly cover the refresher of what we talked about 2 weeks ago at the June 6th meeting. And then we're going to spend the bulk of the meeting doing some final review, addressing some loose ends about the data submission template and guidance. And then if time permits, we're going to do an intro to validation, which is the next topic for the TAG to tackle. And we'll walk through some initial framing for validation and tee us up for our July TAG conversation. So that is today's agenda. And Michelle, if we can go to the next slide, please. Just a quick reminder, June 6th meeting summary, you have the full meeting summary. It was emailed out to you all, and it's also posted on the TAG webpage. I'm gonna just recap where we landed. So in our discussion about provider organization reporting, there was a strong preference to use tax identifiers rather than NPIs. So we are changing the guidance document and template to reflect that. We also had a discussion about including procedure codes for primary care as an option for payers to use to help identify primary care. So this is optional, but we've added the list of primary care procedure codes back into the data submission guidance. We also had a discussion about provider taxonomy and procedure codes, again, optional procedure codes to help identify behavioral health services. We've added that to the guidance document, and we're also going to talk more about the behavioral health procedure codes in today's meeting. We talked about pharmacy rebate data and agreed that we would not stratify into specialty, non-specialty, brand, and generic as part of this initial data submission. So that has all been deleted from the guidance document. And finally, we talked about how to calculate the confidence intervals, and we agreed that we would use standard deviation rather than variance, and we will talk more about that as well. So all of these changes have been updated in the guidance document. The draft of the guidance document that was emailed out yesterday and also posted online has been redlined, so you can see we didn't make a lot of changes other than what we discussed in the June meeting, and we'll finish wrapping up those changes today, hopefully. Any questions or comments about the June 6th meeting? Okay, let's get into the data submission template and guidance. So again, the updated template and guidance, yesterday's date version, was mailed out to you all and is posted online. If you didn't get a chance to see it, you can pull it down from the TAG website. It is the redline version of the guidance document. The template is not redlined, but the changes to the template were fairly minor and are reflected in the redline data dictionary. So you may want to have some of that up, maybe not, but we're going to walk through some specific questions. Next slide, please. We're going to come back to the conversation about the behavioral health provider taxonomy and procedure codes. We're going to talk a little bit more about the provider affiliation conversation we were having and how to do that provider organization reporting. Briefly continue the conversation from last time about allocating pharmacy rebates at the provider level, and then we'll share the guidance and examples that we've added to the guidance document and the supplemental file and how to calculate the standard deviation. Then we will talk about next steps for the data submission template and what comes after that, and then plenty of time for any additional questions that you all have. So going right into behavioral health provider taxonomy and procedure codes. Next slide, please. One more. Okay, so for context, back in May, we agreed that we would add a new service category for professional behavioral health providers, and that this category would be mutually exclusive. It would only include the professional behavioral health services. So inpatient behavioral health services would be reported in the inpatient category, not in this new professional behavioral health category. At the end of that discussion, it was requested that we provide taxonomy and procedure codes to help payers with identifying behavioral health providers and services. Next slide. So to do that, we have gone into a couple of sources and drafted a taxonomy and procedure codes. The taxonomy is a little bit more straightforward. It's based on the Massachusetts Behavioral Health Provider Type List. We reviewed it on June 9th, and there were some questions, some comments and suggestions about adding some Oregon specific behavioral health providers. That was added. And then the taxonomy codes were added. So that is the easy part. The procedure code part is a little bit more complicated, mostly because it's so big. So we started with using Oregon's Health Evidence Review Commission's approved prioritized list and pulled all of the behavioral health CPT and HCPC codes out of that section. So because it's about 6,000 plus rows, we didn't put this into the guidance document. It's in a separate spreadsheet. That spreadsheet was included in the meeting materials today. So we had two questions we wanted to flag for you. One was about the behavioral health procedure codes and whether or not we want to include all of the behavioral health codes that are on that prioritized list, even if it's below the current funded line for Medicaid. They might still be codes that other lines of business are paying for, or they might be services that are happening and being denied. We thought it might be helpful to have a more inclusive set of codes to help identify those behavioral health services. And then we wanted to talk about the actual file format and if this is helpful to you as the guidance you requested. And I'm going to stop there. And it looks like Drew, you've got your hand up. Go ahead.
Yeah. Good morning, everybody. Drew Tarr from Providence. I have a question that is, suppose a carrier is using a categorization scheme like from Milliman's health cost guidelines, which already identifies professional behavioral health services. Are we obligated to follow the taxonomy procedure code definitions provided, or can we use our categorization scheme? And I'm bringing this up because this is already a pretty onerous reporting, requirement. If we can use our the current categorization schemes that we already have built in our systems, it would certainly ease our way, rather than having to code something new.
Yes, and I think this is clear in the guidance, so team, correct me if I don't say this right, but these are optional. This is draft taxonomy and procedure codes for payers that would find this helpful. If you have in-house coding or ways already established to identify this, please use that.
Hi, this is Jeanette Sims from Pacific Source, and I apologize. I have a question. Are these in combination with each other? So you have to have both the taxonomy and the procedure code?
I don't think we specified that. I think it's either or, knowing that some of the behavioral health procedures might be provided in other settings and some of the behavioral health providers might be providing services that aren't these services. Team, do you have more specific guidance on this? Again, I think we were providing this as just sort of optional, and if this is helpful, you can use this, and you might decide internally that it makes more sense to use them in combination because of how you deliver services or how your benefit is structured.
Thank you for answering that. I think this, if you don't use them in combination, I think you have the possibility of including facility-based services, which might misrepresent the category. So hence why I asked the question. If you're using just the procedure codes alone, I think that will be a scenario that payers would encounter if they're not using their own sort of already existing categorization methods.
And is that facility addressed based on we're only looking for professional services here? I mean, is some of that already accounted for?
Well, behavioral health is fairly complicated in the variation and kind of the billing process. It can be fairly variable, especially for things like intensive outpatient and partial hospitalization and some of those services where the billing processes are not always consistent. And so I think I would recommend if you're really trying to just categorize professional services that you consider maybe making it a combination logic versus trying to capture every line item that has the list of procedure codes.
Thanks, Jeanette. Do other payers have comments or reflections on that? I mean, I think because we're proposing this as optional, it feels easy for us to say, optionally, we recommend using these in combination. Does that sound right to everyone?
This is Tracy Cole. I would say yes, you'd want to use both the taxonomy and the CPT code.
Thanks, Tracy.
And Sarah, I think I would just say that this is sort of like a fail-safe option to some extent. And so if you as a payer don't have an in-house way, and I think Sarah has already said this based on the earlier comment, but if you don't have an in-house way of gathering this information, I think in the guidance, we can be very clear what we're looking for, which is specifically the professional fees related to behavioral health. And so this is if you have no other option, here's a way of doing it so that you can have some consistent reporting.
Thanks, Megan. Agreed. This is the fail-safe. as requested. This is not intended to replace anything you have in-house. I'd actually love a pulse check. I mean, how many of you think you might be using this versus something you have in-house?
Providence is going to use in-house.
This is Anna from United. We actually use a combination of both, where we would be using your provider codes and procedure codes.
And Anna, that's a definition United already has built out in-house.
Yes.
Thanks.
This is Jeanette from Pacific Source. I believe we would be using our own in-house logic as well.
Sarah, this is Jared from Cambia. We're still in the process of reviewing the requirements and working with our IT team. So still TBD, but potentially could be a mix or leaning towards in-house where we have them.
Okay. Thanks. That's helpful.
That's the same for CVS Health as well. We want to look in-house to see if we have something that we feel is suitable, but if not, we would use yours as a backup.
Yeah, ditto Kaiser.
Okay, yep, and it looks like Trillium also, you're all still reviewing, would use in-house if you have it. Okay, this is helpful. Okay, so I think maybe given that most of you might have something in-house, we probably shouldn't spend too much time trying to perfect this. Given that, I would say, if we're going to recommend using the provider taxonomy and the procedure codes in combination, it does make sense to include all of the CPT codes, even if it's below the funded line, because that funded line is really Medicaid specific. And I think given the size of the code set, especially if we're including all the codes below the funded line, supplemental file hopefully is all fine for you if you need it. Any concerns or comments about that? Okay, then we will finish cleaning this up, and there will be a behavioral health procedure code or behavioral health code attachment that comes out with the final guidance. Great, let's move on. Keith, did you have is that your hand up?
Sorry, no, I don't.
Okay, trying hard to look at too many screens here. All right, let's talk about provider affiliation. So next slide. Going back to our previous conversation, just to reground everyone, payers as the data submitters are responsible for rolling up primary care providers to provider organizations using your own methodology. So OHA is not going to provide a master crosswalk of primary care providers to provider organizations. That really is your own approach. And there are a number of ways you can do that based on contracting arrangements, based on other algorithms. What we are trying to capture in the data submission template is which TINs are associated with the provider organizations. So the reason that we want to collect that is not for more granular reporting. We don't intend to do any reporting out at the individual provider level, but that we want to understand how one payer is rolling things up compared to another payer, so that when we say here is a provider organization, there's some consistency under that. The goal is that over time, after this initial data submission, maybe the next cycle, we'll have a much better sense of who the provider organizations are, who's affiliated with them. We're essentially going to be able to build a mini directory for this purpose. At the June 9th meeting, you expressed a preference for using the TINs instead of the NPIs. We thought that sounded fine. So then we wanted to just keep talking about how this all fits together. So next slide, please. Michelle, can we get the next slide, please? Thanks. Okay, so after the June 9th meeting, we were having some conversation with the team about how does this actually make sense and how do we actually try to explain what we want, and we thought that trying to draw it out would make sense. So full credit to Megan, who shared some notes that we've turned into this this diagram. So let me walk you through the different layers, and hopefully this will align with where you think we landed on June 9th and make sense of the data submission guidance and the difference between what's reported in tab 3 of the template and what's reported in tab 7. So we've got the individual members. Individual members will be attributed to primary care providers. Again, this is a place where payers have flexibility. Use your own approach for that attribution. That can be member choice, that can be contract-based, that can be utilization-based, and you will flag that. That's going from that member level to that provider level. Then the primary care providers, the individual ones, will be affiliated or rolled up to the broader provider organizations, and that will be using their TINs. So the individual, the highest level, that rolled up provider organization, and all of the total medical expenditure data, the service category breakouts, everything that's affiliated with that provider organization, that is one row in the spreadsheet in tab 3 at that highest level. In tab 7, we would have the provider organization, again, that highest level row, and then each of the TINs that are identified underneath that. So you can see just in this mock-up, there's some overlap here. You see TIN 1 showing up for both payer A and B provider organization. So we're going to be able to use that to help with the linkage on the back end, to make sure that when we're talking about provider organizations, we're talking about the same entities. Next slide. So wanted to clarify a couple of scenarios based on questions that we heard in last meeting. So again, color coded here with the different rows. So starting with the top 2 blue rows and the individual member level or the patient level. So in the scenario where a patient changes a provider and the old provider and the new provider are both affiliated with the same provider organization, that's not documented in the data submission template. Because both the old and new provider are affiliated with the same organization, the member months are reported together, and it's all still in that provider organization highest level roll up. If a patient changes from an old provider to a new provider, and those providers are affiliated with different organizations, that would be captured. The patient's member months with the old provider would be in the old provider organization row, and the member months with the new provider organization would be in the new provider organization row. So essentially that individual member patient's data would be split across the two. At the provider level, if a provider changes practices and both their old and new practice are affiliated with the same provider organization, again, not captured. Both of those practices are affiliated, it's in the same row. If a provider changes practices and the new practice is affiliated with a different provider organization, that is also not captured because we're not trying to track the provider changes. We're capturing the spending for the provider's patients, and those patients are attached. So we're really focusing on not how the provider NPI moves through the system and if one NPI is over here or over there, but more on the changes at the organization level. So again, that bottom row, if a practice changes organization affiliation, so one practice is now acquired by a large health system, that practice is now rolled up in the different provider organization row, and that would be captured. Let me stop there because I know this is confusing. Tracy, hand up, go ahead.
Hi, so I'm not concerned about reporting the member months, but I'm trying to think through how we're going to report the claims associated with those member months. So if a member changes primary care provider, say effective July 1st, so any claims, I'm just trying to think through it and how we're going to do it. I think there might be a lot involved in that, splitting up the claims to report it on 2 separate lines.
Yeah, I think the guidance is written and we're assuming that that split would follow dates of service. So if the claim was pre-July 1st, it would go one place. If it was post, it would go the other. I don't know if that makes anything easier for you, but I think that's how we're thinking about it.
Yeah, I'm not sure because it's at the member level and then everything's rolled up. I guess I'll just, I'll have to read through that and think how we're gonna divide those claims up for every member to be reported in the correct line.
So Sarah, actually, I think maybe one of the questions we need to ask, since the guidance today allows payers to use their own attribution methods, how many payers are attributing members on a more frequent basis than annually?
Mm-hmm.
And so if
well,
yes, let me just pause there.
So this is Drew from Providence. And everyone's going to have attribution. That's going to be their thing, right? But Providence's attribution is an annual based attribution, but the assignment approach will be sometimes, several times, even could be even several times within a month. And then maybe that's a better, probably more of an issue is on the assigned products. You might see members moving around within the year. And that's usually captured, like usually I think we will capture that information and attribute claims based on the member's assignment at the time of the data service. But attribution will just be annual.
Jared, you've got your hand up.
Yeah, I had a question on the previous slide, so I can wait if you want to finish this part of the discussion.
Okay. Do others have thoughts about Megan's question? I think we might need to think about this some more. We're hearing some good considerations. And I think the difference in attribution, I think we might have been hand waving a little bit to what extent the roll up actually matters. So Michelle, if you can, or I guess stay on the slide for a second. I think there's a lot of movement that could happen both at the patient level and at the provider level that won't actually change anything for reporting. But that doesn't mean that you don't have to be able to capture that in case it's a change that would impact reporting. So that make any sense at all?
Sarah, this is Jeanette Sims, and I think that it is possible that different carriers sort of handled these scenarios differently with their provider arrangements. I would perhaps recommend that we try to follow, if there's, if a payer has a consistent method, that they follow that method that aligns with their provider agreements instead of trying to recategorize the population differently for this reporting purpose. I don't know if that makes sense. Some people have an annual process, others may have a monthly attribution process. And so I'm wondering if we can have some flexibility that aligns with how payers administer.
That makes sense. Can we go back to the previous slide? I think these scenarios for me are not an attempt to say everyone has to do it exactly this way. I think it's an attempt to help explain what we want to see, which is that we want everything rolled up to a provider organization and payers have flexibility in how they do that, but that we want to be able to see which of those TINs are affiliated with the provider organizations so that we can track it. How you're doing that, and if that's monthly or annually or your own internal methods, I think we're fine with that. We're not trying to introduce standardization. I think this was an attempt to clarify questions that came up previously. Megan, would you add any clarification to that?
I'm thinking.
Jared, want to ask your question here while we're back on this slide?
Yeah, the split between tax ID and provider organization makes sense from a reporting standpoint. I just was curious when it comes to displaying the results publicly or however they'll be displayed. Do you have any insight as to how those will be shared or displayed?
So to clarify, when we're going to be reporting, the most granularity we intend to get to in reporting is provider organization. So the bottom of that flow chart, we wouldn't go any deeper than that.
And if we have agreements with multiple different provider organizations who collectively join together to manage a set of members, are you anticipating that each organization would be shown separately, or would they somehow be combined? I don't know if there's any sensitivity in sharing different contractual arrangements we have, so we may be limited, but just wanted to get some insight there so I can ask the right questions internally.
That's a good, I mean, that is a great question, because I think we have been making some assumptions about how provider organizations are grouped. And I think, team, Megan, please correct me if this is not what you're thinking, but I think if you have that, if there is a contract with a group of organizations that are held responsible or total cost of care contract for specific members, we would want to see that rolled up, and you would essentially combine those organizations into a provider organization for the purpose of this reporting and for the purpose of accountability. I think. Team, help me out here.
Well, I think ultimately the answer is yes, but the information that you're collecting here will allow you, in a sense, to make another data-informed decision with stakeholder input, if necessary, because as I think that was Jared, if that provider org has 10 TINs, for example, with you, but that provider org is 3 different organizations for, you know, Drew or another payer, I don't mean to call on you guys specifically, but then OHA will have that granular detail to understand who and what those organizations are made of. And I think part of this is about collecting the information to get a better sense of how to do reporting in a reliable and accurate and fair way. So I think Sarah's right. We would want that provider org to be listed as the provider org, but we want the TINs behind that provider org in case there is a need to do different levels of groupings, of course, with stakeholder input.
And I think what Jared is probably leading up to is if there's a difference where one payer has essentially 10 TINs behind a provider organization and a second payer only has 3 TINs and there's some overlap, how do you report that out at the provider organization level? And I think we don't know yet. I think we need to see what's in the data and how much overlap and consistency there is. It is, again, hypothetical scenarios. It is likely that, you know, maybe your group of provider organizations that have come together for the purpose of contracting have come together and are contracting in the same way with another payer, or totally not. And I think we just don't have enough of a sense across the state of what that looks like to be able to group the provider organizations. And we're using this initial data submission to help better understand that. We do not intend to jump right into provider level reporting without a lot more conversation about the roll-ups and with the providers and the payers themselves.
Thank you. That's helpful in answering my question.
Other thoughts, comments, questions about this? If nothing immediately, we have 2 more slides on this topic. Michelle, if you can go to slide 13, please. So one conversation that we wanted to continue from the last meeting was, what about individual providers? So it is possible and likely that you will not be able to affiliate all individual providers with a larger provider organization. So to the extent possible, you should use those existing contracts to help group the providers, just like we were talking about with Jared's question. If you can't group providers together into provider organizations, or if there are some individual providers that you just cannot affiliate, the data should be reported by the individual TIN in tab 3. So this is a place where there would essentially be 1 row for that individual provider. It is very likely that that 1 row, that 1 provider will drop out once everything is rolled up, because they're not going to meet size thresholds, they're not going to meet confidence interval testing. but we don't know that cut point yet because we haven't actually seen how much variation there is. So what we're asking for this initial data submission is that you do report those individual TINs. We'll combine the data across all of the payer submissions and see where we land, and then have another conversation about what that means for those individual providers. Again, the language here is really messy because we've been trying to say we are not holding individual providers accountable. You know, Dr. Smith is not accountable to the cost growth target as their own entity. That said, we need to have a better handle on the data and the composition of these provider organizations. And so we're asking for that. If there are providers that you cannot roll up into a larger provider organization, to report them as their own row if they have attributed members. Does that make sense? Okay, I'm gonna assume that that all made perfect sense. Let's go to the last slide in this section. So one other question that came up, Michelle, next slide, please. Some payers might not have all the detail about local organization affiliations. So we're gonna pick on an example here. So if you're a national payer, you might not know that Silverton Health should be grouped with Legacy Health as part of sort of a full legacy health provider organization. So we would expect to see some variation in the data submission templates. Some local payers who might know about that affiliation would report Silverton Health as part of Legacy. There would just be one row Legacy Health inclusive of Silverton Health. A national payer might not know that there's an affiliation there and might report those as two separate provider organizations. Ideally, theoretically, if this all works, we will be able to see the TINs and know where Silverton Health is being reported separately and being reported as part of broader Legacy Health. And we would be able to group that on the OHA side when we combine the payer data submissions for provider level reporting. In future years, we hope it'll be more concrete and we'll be able to say Silverton Health should be reported as part of Legacy Health or whatever that example is. But we're aware that because we have both local and national data submitters, that not all of the affiliations and the organizations might be clean cut or really well established. Does that make sense? Are there other scenarios where you might anticipate some of this variation, or do you have questions about the proposed approach for handling this? National payers, any concerns? All right. We will leave it there then. I think, again, this was just to help clarify how we're thinking about the provider organization roll up. Hopefully this is helpful for you. If not, or if you have more questions, please reach out about this. But a lot of this really is up to the payers and how you're grouping things and how your contracts are set up. Okay, let's move into the next topic. So allocating pharmacy rebates at the provider level. Next slide for some context. So at the June 9th meeting, as part of our pharmacy rebate conversation, there was a request to consider whether or how pharmacy rebates could be applied at the provider level. Megan shared that no other state has been able to allocate pharmacy rebates at the provider level, given the technical complexity. And several payers indicated that they would not be able to do this with available data. I think we sort of got bogged down in a conversation about attaching the pharmacy rebates to the individual and then the individual to the provider organization, and sort of rolling that thread all the way up. We had some follow-up conversations, and we want to keep thinking about some of the options and implications for allocating pharmacy rebates in aggregate at the provider level. So not attaching those dollars to an individual and letting it sort of follow all the way through the data, but rather we know what the pharmacy rebates are in aggregate because we know that at the payer level, at the market level. And so is there a method to allocate that at the provider level? We think this is going to need some more time to consider. Definitely think through all of the implications, maybe test some options out with you. So we're not going to make any changes to the initial data submission template or manual about this. We're not going to make any changes to our initial plan for reporting, but we are going to keep talking about this over the next couple of months probably. So there were a couple of questions that we just wanted to maybe get a little bit more feedback from you on today. And so the first is for payers, are you taking rebates into account when you reimburse providers for medical pharmacy? So, stay here. Okay, so is it possible that some of those rebates are already incorporated into the reimbursement, or are they really just totally separate and outside of that?
This is Drew from Providence. We do have we do a peanut butter approach on medical pharmacy, and actually in risk arrangements that include retail pharmacy. Also, we sort of peanut butter the net rebate or the ratio of rebate to gross pharmacy costs to the risk arrangement. So you'll see that in our reporting out on the provider incentive, the non-claims component, it would be effectively reflecting the rebate return.
It's true.
So Drew, can I ask a follow-up question to that?
You may.
If that same approach was applied here based on the information that we're anticipating would be reported, would that be double counting the rebate at the provider level?
Let me think this through. My first inclination is to say no. We would be, Megan, I need a chance to think about why I'm saying no, though.
Sure, no problem. I think this is part of that continued conversation, but I think that's something that we want to make sure that doesn't happen, right? We don't want to double count dollars anywhere in the program.
But it's actually no for the same reasons that we wouldn't like the risk return or the result of a provider settlement is that's just algebra that if the pharmacy costs are high or low, right, whatever. I mean it results in a provider incentive result no different than claims like any other claim. In this case, it's just the rebate is just a contra claim. So it shouldn't be like,
so maybe
it shouldn't matter.
So would it be more accurate to say that, Drew, the answer is that you're treating pharmacy rebates, they're not incorporated into reimbursement rates, they're a settlement?
Right, that's accurate.
Okay.
That's accurate, Sarah.
Other payers, can you weigh in on this? How do you handle, are rebates incorporated into reimbursement or are they treated as a settlement?
This is Tracy Cole. I believe they're handled as a settlement as well for us.
Thanks, Tracy. Anyone else? Okay, I think this is exactly why we want to keep thinking about this some more. So no implications for the template or the data submission. This is just a conversation we're going to keep following. As Megan said, we don't want to be double counting anywhere, but there are some implications about what, if we aren't applying pharmacy rebates at the provider level, what that might mean for trend and accountability. So the second question we wanted to ask was if any of you know, just off the top of your head, do you have a sense of how much pharmacy rebates are impacting your trend with and without rebates? We are trying to get just a pulse check on potential impact.
This is Providence, Drew from Providence. I can tell you that the trends gross of rebates is materially higher than the trends net of rebates. I don't know if I want to share the exact number in this setting, but I can tell you that it'll be several percentage points on pharmacy trend itself.
Okay, thanks, Drew. Do others want to share maybe general ballpark and not actual numbers? Should have realized that was a more sensitive question, but does anyone want to share magnitude or general direction?
This is Claire Combs, Pacific Source, and I'll just vaguely agree with Drew that whether rebates are included or not is pretty significant to the pharmacy trend.
Yeah, this is Jarrett from Cambia, and have similar viewpoints.
Thank you. We will keep thinking about this, possibly in a tag meeting, possibly with a call with a smaller group of you to think through this as we have some more questions. So I might send out an email with a call for volunteers who want to continue this conversation, or we might bring it back. I'm not sure. We'll see how it goes. So thanks. And that's where we are on this one. Okay. And next up, standard deviation. Zachary, Yishan, you're up.
All right, so let's take a couple steps back and ground the conversation here. So just as a reminder, the implementation committee directed us to apply confidence interval testing. And so in order to do that, we not only need the count of member months, which we have, the means, which we have, we also needed some value for the distribution. So last meeting, we landed on standard deviation. Between last meeting and this meeting, we really wanted to think about what kinds of things we could provide you all to show kind of exactly what we're thinking about and how we might approach it. So let's go on to the, do we have another slide here?
We don't.
Okay, so just this one. No, it's all good. So we shared, or Sarah sent out an Excel spreadsheet. I don't think we need to go through it in this meeting. But I'll just kind of give you the context and the rationale why we built it. And then I welcome you all to read through that with your teams and come back with any questions or email us. Or if you already have done that between when Sarah sent that out and now, we can talk about it. We can talk about it now. So we wanted to break it out into kind of very specific steps. You know, step one, here's how we do it. There's the allocation, attribution. One thing that is kind of interesting that we discovered and thought we wanted to outline is it's not so much of the distribution of the member costs. So Bob is one member, Muhammad is another member, Sally is another member. And okay, so that's 3 members. They each have a PMPM, and what's the distribution of that? We wanted to be sensitive to the fact that one member may be enrolled all 12 months. Another member may be enrolled just a couple months of the year. Maybe one member is attributed to this provider for part of the year, but a different provider for another part of the year. So we wanted to be more sensitive to the member month count and allow for that factor to kind of be an input in the overall calculation of standard deviation. So as you'll see in the spreadsheet, it's very sensitive to not just the per member per month. Sorry, it's not just sensitive to the members' total costs, but the PMPM and how many months they're enrolled. All that to say, please take a look at the Excel spreadsheet. And then we also added some narrative to the guidance document that essentially is the Excel spreadsheet, but just in Word form, just in narrative form. But they're identical. Yeah, I think I'll stop there and see if folks have questions or reactions, or if folks have even seen the Excel spreadsheet. Maybe they haven't had time to dive into it, and if so, that's okay. Anything that I missed, Yishan? Anything that I missed from our work?
Nope.
You mentioned all of them.
Okay. Well, I would recommend we come back to it and let folks kind of digest the Excel spreadsheet. And there's kind of two questions. One, does the example resonate? And we'll talk about this next time. But one question is, does the example resonate? Does it make sense? Is this something that's doable and you can kind of build it in? We're assuming that it requires a little work, but every analytical statistical program your teams are working probably have a built-in calculation for standard deviation, so that shouldn't be a big deal. But the second question that I'm interested in hearing probably next tag is, what other materials can we provide? What other, do you want another example or something else that will help convey exactly what we're trying to collect?
I just also wanted to share with the tag that we put the specific instructions for how to calculate and the example spreadsheet. That'll all be part of the data submission manual and template and the final release. We also have the full statistical testing write-up, and that'll be a separate document. And I think we're hoping to publish that methodology in the next couple weeks as well. So that's just sort of the broader, here's what we'll do, what we'll pool. We've shared earlier drafts of that with you. It doesn't affect what you'll be doing on your end for the data submission. That's everything that Zachary is presenting today. But we also have the full write-up of what OHA will be doing and all of our steps. And that will also be available for some additional context. Okay.
Great. Yeah, if there are no other questions about standard deviation, I think we can move on. And if between now and the next tag, feel free to email us if you have specific questions or anything comes up or suggestions. We're happy to hear that between now and the next tag. And then I think we'll probably have a placeholder for the next tag too, just to give everyone some space and time to talk about it.
Thanks, Zachary. Thanks, Yushan. Okay, we are just going to hold a little extra time. We're making really great time in this meeting today. So does anyone have any other questions or comments about the data submission template and manual, or any of the changes that we made since the last draft, or anything you'd like to bring up for the group? Tracy, go ahead.
Hi, Sarah. So I was just wondering, at what point are these, the documents that came out today, or not today, the other day, they're not considered final at this point, right? It sounds like there's still some open items.
Yeah, Michelle, can you go ahead 2 more slides? We'll talk about next steps. So yes, the documents that came out yesterday are not yet final. We are going to incorporate any final changes based on today's discussion, based on any feedback that you send us by the end of the week, I'd say. And we will publish the final template and manual by June 30th. So next week, final template and specifications will come out. So this is sort of the last opportunity for, I guess, substantive feedback. Hopefully nothing major will come up at this late in the game, because we've been reviewing this and talking about it for a couple of months now, but we did want to make sure that you had an opportunity to review and comment on the changes that we've been making before we finalize. I also have to say, this is the submission template and manual for the initial data submission. We will continue to have discussions and possibly make changes, and the next template for the next year's data submission, there'll be opportunity to discuss that, and there may be changes there as well. So this will be the final version for this submission.
Thank you, Sarah.
Michelle, can you skip forward to the next step slide, please? Thanks. Yeah, once the template and guidance is final, it will be posted online, and we will send a notification to all of the key contacts for our mandatory and voluntary data submitters. We'll also send a heads up to the full tag distribution list. So some of you will get this a couple times. Sorry about that. But we want to make sure that you know that the final template is when it's out and done. Trey, do you want to talk about the other next steps here?
I'm muted twice. Yeah, so that data submission training is August 4th. So we have our July tag, and immediately the week after, Wednesday, the week after, we'll have that training webinar. And as Sarah mentioned before, it will be recorded and posted. And we're also sprinkling in 3 drop-in office hours. And we'll send the invite to that in a little bit. And so we're just holding these times. We're holding them for an hour. Some of you might have come to our office hours before in other data reporting programs, but we'll be on the line. We'll have staff present there. And there's no agenda. It's just, you can come, show up. If you have any questions about data submission or how to aggregate, fold up the data, come join us at one of those office hours. So we have 2 in August and 1 mid-September for the October 1st due date. Thanks. Yeah, so some of you will get these invites multiple times.
Any questions about the timeline, the upcoming trainings, or any other questions about the data submission template and manual? Okay, please feel free to email us any remaining questions or comments you have. Feedback by the end of this week is really appreciated so we can finalize next week, but we will continue these conversations. Let's go ahead and start talking about validation. So new topic. I'm just going to briefly introduce this and then hand it over to Trang and Liz to provide some framing. So I know several of you had asked, when are we going to get to this? We've also been talking about the importance of validation. And Michelle, next slide. I just wanted to start off by talking about how important validation is. And we want to be really sure that we have confidence in the data on multiple levels. We want to make sure that you're confident in what you're submitting, we're confident in what we're doing with it, you're confident in what we're doing with it, that we have a really strong foundation for the analysis leading into that. And all of that will require validation through multiple stages to make sure that we have good quality data and that everything is complete and that we've gone through all of the right checks and balances. And we want to co-design some of these steps with you all. So Trang and Liz, you want to talk us through what we're thinking?
Yeah, if you can go to the next slide, Michelle. So I think it was mentioned at the top of the hour, the top of the last hour. We are planning on getting way more into this in the July tag meeting, but we just wanted to mention it, talk about like the high level steps right now. So this slide shows, so the big takeaway is you can kind of think of our validation process as like 3 large stages. The initial stage is the initial review of the data submission, and that is by the data reporters. If you've played around with some of the templates, you'll notice there are some checks built in on the TME data input slides, like some of the fields, you can't put a negative number in there or a value that's, I don't know, this format. And so if you put an incorrect format, the cell will turn red. So there's a couple like really basic fundamental structural validations built in. That's also part of that validation process is also going to be going through the questions on the cover page to make sure that all the T's are crossed, all the I's are dotted, stuff like that. We will still check a lot of those when you submit the data to us, but that's the first stage. And I realize we are explaining these stages a little bit in the forthcoming slides, so maybe I should just save it for that. But from this slide, you'll see, yeah, there's an initial stage that's primarily built into the TME Excel template. This second stage is review of the data files, and that's going to be done in-house by our staff, primarily Liz. And then the third stage is going to be the back and forth review with payers and provider organizations based on what we found in the previous validation stage. If you can go to the next slide, Michelle, which I pretty much already talked about. Yeah, so this is what I was getting into in the last slide. So there's a bunch of built-in validation checks. We're still going to run through that when you submit it to us. And if necessary, we will reach back out to you, hopefully very quickly. These will be very quick to find. If we do find something, we'll reach back out to you to clarify, maybe correct some errors in a possible resubmission. Once you pass this stage, we'll go to stage 2. Next slide, Michelle, please. So stage 2 is where the more exciting stuff happens, at least, especially for Liz. So I'll let Liz talk about this a little bit.
Thanks, Trang. So for those who haven't met me, I'm Liz McCarthy. I'm a new analyst to the team, and I'm super excited to work with all of you. And I feel like we are going to be communicating a lot, especially in terms of validation. And so during the second step of the validation process, we're primarily going to be looking at the payers, so the submitters data, and changes from year to year. So for example, is the percent change from 2019 to 2020 data, is that within a certain threshold that OHA will determine? And if it is, awesome, it's past that initial check and it can go on to the next round. Otherwise, if it doesn't, then we'll reach out to you guys and confirm, is this data correct? Is there a typo? Can you explain why the percent change was greater or less than what we were anticipating? And so there's going to be a lot of back and forth on a variety of different kind of levels. So we're going to start at the really general level, and then each step will get more and more and more and more detailed, so we can make sure that all aspects of the data are as validated as much as we can. Okay, next slide. And then Trang, I'll pass this one back to you.
Okay, next slide, Michelle, please. So if that stage gets passed with those checks, then we'll do, kind of the big kahuna check, looking at those levels of reporting against the cost growth target. And at this point, we will be reaching out with payers and provider organizations to talk about the submitted data, see if anything was unexpected along the way. At this point, we'll have a lot of back and forth. Maybe not a lot of back and forth, but and yeah, maybe a lot of conversations, one-on-ones planned and such. So the big takeaway from all 3 of these stages and ramping up for our July tag meeting is that we have validation processes in the works. We've got a workflow we will present to this group next month. You'll note all along the way there are multiple points of contact with data submitters to make sure that this data is accurate and correct as we're using it. And we'll send out the workflow and the steps before our July meeting, hopefully at least a week, maybe before, so folks could have a little more time to look at it for discussion in the July tag meeting. That's July 28th. But after, this high level overview of these 3 stages today, are there are there things or checks that you all are particularly interested in, or you want to make sure that we are building it in early. And if none are coming to mind, that's totally fine. We'll have another opportunity to talk about it. But if you had something today, we'd really like to hear it.
We have a question in the chat. Let me read it. I think it came just to me. Would it potentially save a round of initial validation to have a check tab in the workbook? This would let payers know what checks OHA is doing, or payers could create their own check tab, or will the workbook, will the template itself be locked down to that? I think, Chang and Liz, correct me, I think we're hoping that what's built into the template is in stage 1 is part of that, but I think what they're asking is, could we also build part of stage 2 into the template?
Yeah, that's a good question. And I think for this initial year of submission, we're going to be keeping the template as is and trying not to bulk it up first. But this is something we could revisit after the first year of submission, after we see what the data looks like, after we get a handle of, running through some of those post-stage 1 validation checks. And it could be that next year we'll want to put some of those checks further in the beginning and incorporate them as part of stage 1.
And let me add, we fully intend that our stage 2 checks will be transparent. There will be summary public-facing information about what we're looking for, what we're doing. So you'll be able to compare against that, even if it's not built into the template. We don't intend this to be like a top secret stage 2. Megan, comments?
So I would just add the stage 2 isn't a perfect science. That being said, there are sometimes reasons why variances are completely expected and reasonable. And so building some of that in is important and can be done. And I think those of you who participated in other states, or at least in Connecticut, have seen something similar, but it's not every single issue that comes up can't necessarily be validated right away. So it does take, Liz's expertise and other analysts to go through the information.
Thanks, Megan. And I also want to add that, somewhere between stage 2 and 3 is when conversations about what's actually happening, reasonableness, all of that more subjective piece comes in. And again, that's probably also not going to be a hard line. It's going to happen somewhere in that transition between what we see in those stage 2 validation checks and those conversations with you all. We've been talking about this since the implementation committee recommendations about what are those criteria for reasonableness, understanding what we're seeing, understanding why we're seeing what we're seeing, making sure that we're in agreement about what we're seeing. And so while we do intend to build out some processes and maybe some starting questions for those conversations, a lot of this is going to be really dependent on what we see, and it will really be payer specific depending on what's in your data. So I think we are committing to being as open and transparent as we can be about the process, what we'll be looking for, how we intend to have those conversations, but recognizing that it's not going to be just a final pass-fail checklist at any point in this process. Kristen.
Yeah, thanks. I think I would just say that a conversation directed or with providers that will be, although the payers are reporting, the information affects our provider community equally. And whether or not we're being held to, standards or thresholds at this point, the fact that the information will be public is really, equally as important. And so I think if the authority could consider having a meeting with providers, talking through how this is coming through, making sure they understand the timeline, and then understanding the length of time in the phase 3 for validation, because I'm not sure that everyone understands the level of information and the methodology that's currently being used, just because it's been really primarily focused on what's possible from a provider's or from a payer perspective.
Totally. Thanks, Kristen. And I think this is one of those places where we've got a little bouncing back and forth between what the tag is working on technically and those sort of technical checks and some of the conversation that we intend to be having with the implementation committee this summer about provider outreach and messaging. So I think some of what you're saying about letting providers know what's coming, talking about the timelines and the processes, that might be more from the implementation sort of communication strategy perspective rather than from the technical. But I think there's some bleed through in this conversation.
Yeah, I mean, I get that. I think the implementation committee is a different level, a level of experts within the provider communities of CFOs or finance teams would probably be really beneficial, in my opinion.
Yeah, thanks for that. If you have concrete suggestions or ideas about how that conversation might happen or how it could happen, I think we're really open to hearing that.
Okay, I'll connect with the Prize and the Hospital Association and see if we can't coordinate directly with you.
Sounds great.
Thank you for the consideration.
Yeah. And I think one conversation that we haven't gotten into, and I think we will want to talk more with the tag and possibly with this provider group as well, is concerns came up during the implementation committee conversations. It's pretty straightforward to say, here's what we, it's pretty straightforward to say, here's what we see in the payer data, go have a conversation with the payer. That's a one-to-one connection. But once we start having the conversations at the provider level, that's coming from multiple payer data submissions. And so there was a request previously, can OHA not meet directly with the provider organizations, but can that be a three-way conversation with the payers as well? And I think the answer was yes, but we'll have to figure out what that means because we're talking about multiple payers, multiple providers, and that relationship just sort of multiplies out pretty quickly.
Well, and that would be a bit of a burden on the payers too, right? I mean,
yes.
If we had to start meeting with every provider, but this is Drew again. Like part of me kind of hopes that if the OHA is going through all this validation with each payer, that the OHA can then represent the payers as they talk with providers.
I think I'm hoping that we also have a really strong validation process and that gives us a lot of confidence going into those conversations. I think, and Megan, please chime in here, one of the pieces where this is a concern is in other states, what OHA is going to see and report as the provider organization trend once all of the payer data are combined is not necessarily what the provider organization has been seeing directly with an individual payer. And so it's that disconnect that needs that three-way conversation to true up.
I think that's exactly right, Sarah. In our experience, the conversation between the payers and the providers was really important. And as you can imagine, the total cost of care contracts have a different methodology than the cost growth target. And so there are some legitimate reasons why providers see different trends in their contracts than they do on TME. And it requires some stakeholdering to, not only on OHA side, but I would anticipate there being some conversations between payers and providers. And in Massachusetts, for years, they've been doing this. The organizations at the state level take a completely backseat in it, and the payers and the providers are the ones that have the conversation. So I think it sounds like OHA is hoping for somewhat of a blend of that model.
Yep, but I think that's all very, this is all very hypothetical at this point. We want to make sure that we're validating and having a lot of confidence in the state level data, the market level data, the payer level data. There's so much complexity with the provider level. What we were talking about before with the provider organization roll up and even knowing which, like, who are we talking about and who needs to be at the table, especially if we've got multiple organizations sort of in various contractual arrangements. So I just think there's a lot in this layer that we don't know what we don't know yet. And we're open to figuring out a process. We want to be transparent about that. We want to make sure that there are those opportunities for conversation and validation, but what that's going to look like, how complicated it will be, and the timeline for that might be a little bit later in the process. It'll be much more, again, hand wave straightforward to have the direct conversations with the payers about their own data submission and make sure we have confidence in that as we move forward into the provider level. Richard, you have a comment.
Yeah, this is Richard from Comagin Health. This is an important conversation. Oregon does have a leg up on perhaps some other states because Comagin Health has been delivering total cost of care to primary care providers for years now across multiple payers. So I'm not saying that our numbers will agree with what the OHA calculates. We understand there's completely different methodology, but the idea of providers seeing how they compare not just within one payer, but across all their payers is something that's not unknown to Oregon primary care providers and their organizations.
Thanks, Richard. Other questions or comments about validation, concerns, things you'd like to discuss in July, concerns about the process we've outlined? Things you like about the process we've outlined. Let's be positive. Okay, if nothing else is immediately coming to mind, as always, please feel free to email us with your thoughts, and we will be getting some more details out, particularly about stage 2 and the workflow in advance of the July TAG meeting, and we'll spend a lot more time talking about that. Yeah, Michelle, you can go to the next slide. Let's go ahead and wrap up early. So our next meeting is July 28th at 10. We'll talk more about validation. Between now and then, the final specification, the final guidance and template will come out next week. And we will also be pushing out those appointments to you for the data submission training and the office hours. Any final questions about anything we've talked about today, process, what's coming next? All right. Thanks everyone for joining a second meeting this month, and we will email you all next week. Thank you.
Thanks everyone. Bye.
Thank you.